Okay, so here we are. Good evening and Happy New Year to everyone. We are thrilled to kick off our first PEP Talk, Patients Educating Patients of 2024. And tonight's topic is orthopedic surgery and blood clots, what we all need to know to stay safe if you're having orthopedic surgery. Tonight, I am joined by my fellow moderator, NBCA board member, patient liaison, and six-time blood clot survivor, Todd Robertson. Todd, thanks again for joining tonight.
You're welcome. Hello, everybody.
And we are also joined by our clinical expert, Dr. Sam Berkman, who is a hematologist and medical oncologist specialist at UCLA/Cedars-Sinai in Los Angeles. Dr. Berkman is a world-leading thrombosis expert who received his medical degree from Tufts University. He did his internship at Cedars-Sinai, a fellowship at UCLA in hematology, a fellowship at the NIH in oncology, and he is a clinical professor of medicine in the Division of Hematology Oncology at UCLA. He is also a board certified in internal medicine, hematology, and medical oncology. Dr. Berkman is a member of the National Blood Clot Medical and Scientific Advisory Board. We are thrilled to have you tonight. Thank you for joining us. We are very informal here at NBCA, so we will now transition from Dr. Berkman to Sam. And so it'll be Leslie, Todd, and Sam tonight. However, before we get started, I do want to mention a few things. Tonight's event is for educational awareness only. We are not here to give medical advice to anybody. Each of us is unique, and we should be speaking to our own individual doctors or healthcare providers about our own medical situation. And then we have a few things that we do want to share with you this evening as well, which is NBCA has launched its first podcast series, and there'll be information in the chat about that podcast series where we are highlighting everyday heroes in the thrombosis space. So with that, I'm going to turn it over to Todd for some polling information.
Yeah, like we always do, folks, we're going to have some polling questions for you so we can gather a little bit of data because we're curious. We want to know what you're thinking. Have you had an orthopedic surgery before? Yes, no, surgery is scheduled, or I'm a caretaker of someone that's been going through this. Our second question, if you said yes to question one, meaning you've had orthopedic surgery, did anyone talk to you about the risk of blood clots? Yes, no, not available. If you said yes to question one, meaning you have had orthopedic surgery, what procedures did you have? Select all that apply. Did you have hip replacement, knee replacement, ACL reconstruction, shoulder replacement, knee arthroscopy? I butchered that one. Other or not available. And the last question, have you ever experienced a blood clot because of this? Yes, pulmonary embolism. Yes, a DVT. Yes, a PE and a DVT, or no. If you could just answer those questions, then we're going to just share the results real quick. Give everybody a couple seconds to get them all answered. And here we go. So have you ever had orthopedic surgery? Yes, 50%, so over half of our audience. No, 36%. Surgery is scheduled for 11% of you. And I'm a caretaker, 4%. We know we do have caretakers out there, and that's a tough job. 0% with not available. Our second question, if you said yes to question one, meaning you have had orthopedic surgery, did anyone talk to you about the risk of blood clots? Yes, 25%. No, 44%, and 31% unavailable. If you said yes to question one, meaning you have had orthopedic surgery, what procedures did you have? Hip replacement for 8% of you, 13% had knee replacement, ACL reconstruction at 8%. Nobody had shoulder replacement in this group, and knee was 33%, other 25%, not available 29%. I'm sorry, there is that one last question. Have you ever experienced a blood clot? Yes, pulmonary embolism, 14%. Same for DVT, 14%. Both PE and DVT, 28%. And no said 45%. So thank you very much for participating in that poll. Back to Leslie.
Wow. So for those that did have orthopedic surgery, it does seem we have our work cut out for us to really educate people more about the risk of blood clots and orthopedic surgery. So this is a really super important topic as more and more people get orthopedic surgery, and also we have more outpatient as well. So Sam, we're so thrilled to have you here. So we know that orthopedic surgery, particularly hip and knee, but others as well, is a leading cause of venous thromboembolism. So tonight we want you to educate us on a few topics. The first is, why is that? Why is it so prevalent? How can we protect ourselves if we are planning on orthopedic surgery? And then we want to have a conversation with you about anticoagulants, what patients should be taking, aspirin, DOACs, how is that decided, et cetera. I know you brought some slides with you to share with the audience. So maybe what we should do is jump into the slides first and continue the conversation.
Okay, that's a good idea. Let me just try to share my screen here. Hold on. So, so what I'm going to do is I'm going to start this as soon as I can. Okay, can you all see my slides?
We can.
Yes.
Good. Okay, so orthopedic surgery 2024, and that's got my name on it. I have one disclosure. I'm a speaker for Janssen Pharmaceuticals, manufacturer of Xarelto. And let me just see here. Okay, so we're going to talk about hip replacement. It's called THA, total hip arthroplasty. That's a fancy name for it, but it's a hip replacement. A knee replacement, then a traumatic fracture, then arthroscopic surgery. That's like if someone has a torn meniscus or a torn ligament, and it's done through a scope. It's not as big a deal, but there still can be risks. And what about the patient who's taken anticoagulants to begin with? People who have atrial fibrillation are frequently older people, and so are people who get hip surgery. So frequently you've got a person who was on anticoagulants to begin with. So how do you handle those? Those are the subjects I'm going to be talking about in the next 15 minutes. So this is called Virchow's triad. And, it's hard to see, lecture on venous thromboembolism without someone bringing up poor Virchow, who died 120 years ago. It's about time we left the man alone. He was an interesting man, by the way. He was a very famous politician in Germany, in addition to being a doctor, and he basically antagonized the head of the government so much, Bismarck, that he challenged him to a duel. But anyways, as far as his triad's concerned, when you get hip surgery, you got stasis because the person's going to be immobilized and they're going to be on the table. And also there's injury to the vessel wall from the surgery. And when you injure the vessel wall, it activates all these clotting factors you see on the right-hand side of of the screen. So you have this whole triad here. So it used to be back in the 60s, before we used anticoagulation, that the risk was felt to be as high as 30 or 50%, including asymptomatic cases. But when we started using anticoagulation, it was down to 5 to 10% in the 90s. And now today, the risk is about 1.5% because we have less invasive surgeries for hip and knee, early remobilization, regional anesthesia. But as I said before, surgeons tend to treat everybody the same, either with aspirin, if that's what they use, or with DOAC, if that's what they use, or with low molecular weight heparin. They don't tend to individualize treatment. They kind of use their drug and use it the same in everybody. And you can see here on this slide that it's very effective, all of these drugs, in preventing pulmonary embolism. Most of the drugs you see listed on this slide will result in a pulmonary embolism rate of under 1%. So they're very effective when you give them. And what I'm going to get into is which ones should you use and which ones are basically not to be used. Now, as I said before, this is an article from a Journal of the American Medical Association regarding the use of aspirin for venous thromboembolism and hip and knee replacement. And if you want to read the article, it's written right down at the bottom of the slide. And it's a meta-analysis of randomized trials. A meta-analysis means that it's a study of studies. And the fact these studies are randomized, the meta-analysis is only as good as its component studies. And if the studies are randomized, that means they're excellent studies, because a randomized study means that both sides are exactly the same. So any outcome that ensues from a randomized trial is due to the intervention and not due to the fact that the groups were of different composition to begin with. And you're going to be equal on anything. I mean, even things that are important, like previous VTE, or things that are important, and even things that aren't important. You're going to have the same number of murderers on each side and the same number of scratch golfers on the same side. So it's matched for everything. And what it showed in this result of this trial, this meta-analysis, was that aspirin was not different from the other anticoagulants. So let's take a look at this. I've circled basically what you can see here. On the right side is called a forest plot, which says aspirin's better, and whatever it was compared to is better. And you see there's about 15 different trials here. They're all randomized, and most of them, they're exactly the same. There's a few where aspirin's better, and there's a few back in the 80s where the comparator was a little better, but aspirin turns out to be the same. This is the summary point, and you can see aspirin stacks up just as well in hip and knee surgery. And these two places I have circled, this article, these studies both gave 5 days of rivaroxaban and then went to aspirin for 35 days. This study in 2013, which showed almost superiority, was against low molecular weight heparin. This one was against rivaroxaban. But you can see aspirin is a real player here. And also, basically looking at this, you can see that DVT and pulmonary embolism were the same with aspirin and with the DOACs or low molecular weight heparin or whatever. Here's another trial.
Sam, before you move forward, just a question for you. A few pages back, there was a ranking for the different anticoagulants. Everybody had an A, and at the bottom of the page, aspirin had a B. Why is that if it's showing the same level of effectiveness?
Yeah,
why does it get a grade of B?
Well, you can see the number is just as good, 0.1 to 0.3. The number here is not worse. I think probably prejudice. These grades are determined by a group of people who get together, and that grade means how good's the evidence. So I think basically there may be a little bit of prejudice there, so they basically gave it a B. But the fact is, if you look at the number, the total rates, 0.1 to 0.3, it stacks up very well against all the others. So I really think that randomized trial, which involves about 5,000 patients, all randomized, speaks more. They say expert opinion ranks the lowest of any form of evidence in the bottom. Expert opinion, then a cohort study, then and at the top is a randomized trial, and above that is a meta-analysis of randomized trials. So when you've got a meta-analysis of randomized trials saying one thing, and you got expert opinion saying the other, I would go with the meta-analysis of randomized trials. The word expert's a funny word. We have two definitions of it in our hospital. One is someone from out of town. That's the first definition. The second one comes from Niels Bohr, who won the Nobel Prize in Physics in 2024. He said an expert's someone who's made every possible mistake in a very limited area. So much for expert opinion. That's kind of a long-winded answer to your question.
Okay, thank you.
Okay, anyway, so basically, so this is the study basically comparing rivaroxaban versus enoxaparin, and showed that there was no difference. I've circled no. I don't know if you can see these circles on the slides, between venous thromboembolism or bleeding. So that DOACs tend to be ranked above low molecular weight heparin, because if you're going to give low molecular weight heparin as an outpatient, that's about 35 days of injections for hip surgery and 14 days of injections and for knee surgery, and people don't tend to like that so much. All right, so let's talk about now, we've talked about hip surgery, talked about knee surgery. So let's talk about, trauma is the last one. Let's talk about someone who's already on anticoagulants to begin with. What do you do? So this is a study. People who were not on warfarin, they were on DOACs. And basically, it was a study that looked at well, how do you handle the DOACs? Do you need to bridge people or anything? So basically, what they did was the DOAC regimen was admitted for 1 day before a low bleeding risk procedure and 2 days before a high bleeding risk procedure. And they were resumed 1 day after a low bleeding risk procedure and 2 to 3 days after a high bleeding risk. So which is a high bleeding risk procedure? Orthopedic knee surgery and hip surgery are considered high bleeding risk surgeries. Therefore, in someone who's going to hip and knee surgery who's on a DOAC, you want to hold the drug 2 days. So if the surgery's on a Thursday, your last day is Monday. You don't want to give it Tuesday. You don't want to give it Wednesday. You do the surgery on Thursday, and you start it back on Sunday. So you hold it 2 days afterwards. So that's the recommendation from this trial. And this trial basically showed that where the 30-day postoperative risk of major bleeding was less than 2% and the risk of stroke was less than 1%. So I think that if you're going to take someone who is on apixaban or rivaroxaban for hip or knee surgery, you need to stop it 2 days before, meaning there will be 2 days where they don't get it at all before the surgery. Now let's look at Coumadin. So this is called the Bridge trial, done by the same people, but this involves Coumadin. So what if a person's on Coumadin? You know, people aren't on Coumadin so much anymore because of all the reasons I'm sure you've discussed in your previous webinars, so I don't need to go over them. But basically, there's still some people are on them because they've got heart valves, or they just don't want to pay the extra money for the DOAC, or they've just used to warfarin. So anyways, basically, this trial was very similar. They resumed the medication 12 to 24 hours after a minor surgery and 48 to 72 hours after a major surgery. And just like the other trial, major surgery was considered orthopedic surgery. So 24 hours before, 48 hours afterwards.
So Sam, can I ask just one question real quick? So about the bridging, is this going to be true for everybody, or what about, so here's my situation, factor V Leiden homozygous. I've clotted in 3 days when I've been off anticoagulants. So anything major that I have, I've had both shoulders, rotator cuffs repaired. I had a tumor taken off my liver during a very long surgery. I can't remember how I was bridged exactly, but I know that I had to start Xarelto the day after those surgeries. My risk for clotting was a lot higher than my risk for a bleed, and I guess they knew that over my history. So this may vary from patient to patient.
Okay, so just let me show you the data. You know, so this involves a large number of patients, 918 that had no bridging and 895 that had bridging, and basically showed that there was a very low outcome of stroke and embolism, etc. Now that's those patients. You know, that's why it's very important to talk to your patient, because if you've got a patient, despite these statistics, you know, if you've got a patient who clotted on day 2 after surgery, well, you're going to tailor your treatment to that individual needs of that patient. You're not going to go by these statistics. In other words, these are like guidelines, but guidelines take you so far. You've got to also consider the specific circumstances of your patient. So if Todd's telling me, if I'm telling Todd, you know, I'm going to start you because this is major surgery, and people who are orthopedic surgeons who are doing hip surgery do not like starting people back so fast if they don't have to, because they say they get in more trouble with the bleeding than the clots. But if he tells me, well, listen, I've had 5 clots, number 1. Number 2, the last one I had was on day 2 after surgery. Well, I'm going to start him earlier, and I'm going to just tell him, look, there's more of a chance you might bleed than somebody else, but I would rather deal with a bleed than a clot. Now, some orthopedists differ from me on the grounds that they'll say, yeah, but if you get a bleed, that means you got to stop all the anticoagulation, and how are you going to protect the person from a clot if you have to stop the anticoagulation. Are you going to put in an IVC filter? We don't like these. So there's a lot of pushback here when you come to talking to orthopedists who do a lot of hip and knee surgery. It's not just like a conversation where I call him up and he says, "Oh, sure, Sam, whatever you say." That's not the way it usually goes.
Yeah. Thanks, Sam.
Okay, you're welcome.
So just before we move forward, so for everybody who's on the call, who's already had a VTE event and they're planning to have orthopedic surgery, important to have that conversation with the orthopedic surgeon and ask for the consult with the hematologist.
Yeah, or, yeah, I mean, there's some internists, some of the real experts in our field, like Scott Cates, who's a member of the board, he's an internist, or Alex Baropoulos, who I guess is not a member of the board, but it's, so, if somebody's an expert in thrombosis, they don't absolutely have to be a hematologist, but they got to be somebody who's really involved with thrombosis and really involved in the field.
Okay.
Okay,
Great.
so let's go on to the next slide here. Oh, so yeah, so here I'm going to talk about arthroplasty. So this is the person, frequently it's a younger person. It's a younger person who's got to have like a torn meniscus or a torn ligament or something. So this was a study done again, a New England Journal. New England Journal, by the way, only publishes randomized trials, if you've ever noticed that. Most of these other journals, like you'll see these large observational trials, randomized trials are superior because, as I said, they're completely matched. So these are 1,500 patients for arthroscopic knee surgery. So one group got prophylactic dose low molecular weight heparin for 8 days, and the other didn't get anything. And there basically was no difference in the VTE in the groups, as you can see, 0.7 versus 0.4. One patient in each group had major bleeding, but excluded from this trial were people who had previous history of venous thromboembolism. So Todd, you would not be, this trial would not apply to you because you have a history of a VTE, or if the woman was pregnant, it wouldn't apply to her. That's another thing, if people read these articles and all they read is the abstract and the conclusions, they're not going to understand which patients it may not apply to. So that's why when you read something and you're going to make a recommendation to a patient, you've got to know the details in the story, because Todd would be excluded from this trial, and he would definitely get low molecular weight heparin because of his history. Okay, but if you just went by these results, if your doctor just read this article and said, "Todd, you don't need it, look at these results," that's why, again, you got to talk to the patient and find out, what other risk factors he has, what his history is. Okay, so
all a part of being your own advocate, right? You got to have a communication. Got to
yeah,
be able to
yeah,
discuss.
you've got to tell them what your history is exactly.
Yeah.
In a perfect world, your internist would send a summary to the doctor, but doctors today, they have so much to do with their paperwork and everything. It's a miracle they get that done. So I wouldn't count
That's
on
right.
that, fortunately. All right, so let me just finish up by going through the guidelines from the American Society of Hematology about hip and knee. So basically, they suggest using either aspirin or an anticoagulant. Okay, now, as far as which anticoagulant is concerned, basically, they recommend a DOAC over low molecular weight heparin. So it's either aspirin or a DOAC. But if someone does not use a DOAC for some reason, they're allergic to it or whatever, then they recommend, if a DOAC's not used, low molecular weight heparin rather than warfarin, because warfarin takes too long to work. It takes about 3 or 4 days to work. So for a patient undergoing hip fracture surgery, we usually treat them kind of like a hip replacement, frankly. But the official guideline here says using low molecular weight heparin or unfractionated heparin, but it's based on very low certainty. Again, a lot of this has to do with how immobilized the person after is, but a hip fracture, I would treat similar to a total hip replacement. And the last one is for people undergoing, yeah, I got that one. Okay. All right. So that's it. So that's my slides.
Okay, so let's just do a little bit of a recap because I'm always suspect of statistics that look really good, and then we end up being the ones who get the blood clots. So I want to come back to my initial questions with you. We know that, we see a lot of patients that are having hip and knee that are getting blood clots. We're seeing people with ankles. We're seeing people getting arthroscopic, getting some of these blood clots. Why does it actually occur in orthopedic surgery?
Well, like I said, it's really Verko's triad. It's really a combination that you're really instrumenting and manipulating the leg, and the person's at bed rest, and the surgery generates, when you cut people and you traumatize their leg and you rotate their leg, you generate a lot of thrombin. And so basically it activates the clotting system. Also, the person is immobilized on the table for the length of the operation, and they're not just up and around like they usually are afterwards. They're immobilized. So it's a combination of stasis because of the prolonged immobilization, trauma, and hypercoagulability, et cetera. And so those are the reasons.
So more and more, it seems, orthopedic surgeons are trying to get their patients out moving sooner and sooner. So that might help with alleviating the risk of getting a VTE. And then I just want to come back to, the type of anticoagulant that patients should be on. So it sounds like if you don't have any risk factors or preceding risk factors, i.e. you haven't had a blood clot historically, you're not pregnant, et cetera, the data looks pretty good in terms of taking aspirin after you've had orthopedic surgery. And that's regardless if it's hip, knee, shoulder, ankle, any other orthopedic spots that I can find. It's regardless of where the location is, but aspirin seems to work pretty well. Is that correct?
Well, we don't have a lot of data on the ankle with aspirin. We don't have the data with that we have with hip and knee surgery. But again, you're going to want to individualize things, because I think someone like Todd, I don't think I would put him on aspirin. It's kind of a little counterintuitive, because you see, if you got a venous thromboembolism, no one would put you on aspirin. That's number one. Number two, if you got a blood clot, if you had atrial fibrillation, and you wouldn't get put on aspirin to prevent an embolic stroke, okay? For both of these things, you'd get DOAX or Coumadin or something, but not aspirin. Also, the Einstein Choice trial, people after 6 months of anticoagulation, there was an 83% reduction in recurrent venous embolism for rivaroxaban versus aspirin. So in 3 different areas, aspirin does not match up. It happens to, in hip surgery, it matches up. But I think that I would have, as a general antithrombotic drug, more confident in a high-risk patient in going with an anticoagulant. So if I had someone like Todd, I would use an anticoagulant. I would not use aspirin, despite the statistics I showed you. I think that you have to individualize, and I would say that for the arthroscopic surgery, even though I just showed you a very good randomized trial that showed that not given any anticoagulants was good as low molecular weight heparin. If it was someone who had, like Todd's situation, I would give them the low molecular weight heparin. So it's very important to individualize and to basically get someone to make this decision who does this all the time. Now, some orthopedists are very good. Some of them know the literature really well, and that's fine. And plus, they got a lot of firsthand experience. So if they get burnt, they're going to remember that. So these guys are not just going by the literature, but they're going by their track record, which is good to a point. But I think if you got a special case of someone, you don't want them just doing what they always do. There's a tendency of the surgeon to want to do what he always does, because that's what he's comfortable doing. And I think you just can't allow that in someone with special circumstances.
Okay. And then, Sam, for how long should people be, focused on signs and symptoms of a blood clot post orthopedic surgery? I know the treatment in terms of aspirin versus DOAC is one thing, but how long are they at risk for? I mean, is it a month? Is it 3 months? Is it 6 months?
Good question. Well, they should be treated for 35 days for a hip, and they should be treated for 14 days for a knee. But I would say they're at risk for 3 months. There's some risk. And, yeah, that comes up because, people, they hear about this. So, they're going to have some discomfort in their leg because they had surgery in their leg. So sometimes someone who's really sensitive thinks any pain in their leg is a clot. So we have to send them a few times to the vascular lab till they're convinced that they don't have a clot. And then they're okay with it. But the risk, and it also depends on how ambulatory they are afterwards. In other words, how soon they reach ambulation. Somebody, they say that trauma and surgery, the length of anticoagulation is 3 months if you get a clot, because the risk is only about 1% for the rest of the year. But if after 3 months, this person who's had surgery or trauma is still in a wheelchair, then you just can't go by that. You just can't go by that. You got to go by their circumstances.
Good point. So for somebody who ends up, unfortunately, getting a blood clot, either a DVT or a PE after orthopedic surgery, are they considered to be provoked, and therefore they aren't at higher risk down the road of another blood clot? Or would you consider that to be a risk factor for them going forward, potentially getting another one should they have a different surgery or what have you?
So, good question. So the answer to your question is they have a risk in the upcoming year of 1%. So everything else being equal, they don't need to be treated for more than 3 months. But anyone who gets a blood clot for any reason is at increased risk of getting another blood clot versus someone who has never gotten a blood clot. And it's not just in the same leg, it's in either leg. So it's not just a matter of the blood vessel being damaged and predisposing itself to clot locally. They can get them in the other leg too. Something happens to the clotting system. And anybody who's had a blood clot, even if it was a provoked clot, I would advise them, if they're going to travel by air for over 4 hours, to take maybe an aspirin or maybe 2.5 of Eliquis or 10 of Xarelto if they're going more than 4 hours, if they have a history of a blood clot, just because they are at increased risk. Not enough risk to put them on long-term anticoagulation, but still more risk than someone who's never ever had a blood clot.
So it's kind of a good reason to sort of live like you're prone and manage the risk factors, right? Like you're saying, we're talking about travel, but the other things, dehydration and all that stuff is just, things we're going to have to keep an eye on. But when it comes to after the surgery, where does compression fit in with all this? What do you advise on compression? How effective is that? Do they need to see a specific vascular surgeon for it? What's your opinion on compression?
So compression doesn't prevent blood clots. Prevention may help with post-thrombotic syndrome, although that's very disputed also. But I think a person got swelling in their legs, compression does help that for sure. I don't think compression particularly helps blood clots, but there's no downside to it unless it's too tight, and then it causes a problem with the skin. They
need to be, if you're going to wear compression, they should be fitted properly, right?
Oh yeah, they should be fitted properly. Absolutely, they're ancillary.
Okay. I want to, at the risk of you wanting to kill me here with these questions, I keep coming back to this, and we've had a few people in the chat also bring this up, and this is my question too. So, aspirin is an antiplatelet of red blood cells, correct?
Yes.
But a DOAC is an anticoagulant.
Right.
So why wouldn't people just get the DOAC as opposed to the aspirin if we're trying to prevent a VTE after orthopedic surgery? Is it purely because of bleeding risk?
Yeah, exactly. In other words, orthopedists do not like bleeding. They really don't. They think it ruins their work. And then secondly, then they can't anticoagulate somebody if someone's bleeding. Then they have to deal with maybe a filter. So the question is that because aspirin has not stood up to anticoagulation in so many other areas like atrial fibrillation, venous thromboembolism, extension treatment, that it hasn't been used very much. But I think to take a silo effect approach, whereas aspirin is good for arterial things and anticoagulation is due to venous things, there's a connection between the two. There are common denominators. And, I think that thrombin, one of the ways thrombin works is it activates platelets by platelet activator 4 receptors. So that's one of the ways that anticoagulants work as well. So I think that basically there are common denominators between venous anticoagulation and arterial anticoagulation. And the bottom line is in the studies, a meta-analysis of randomized trials of 15 trials, a very powerful trial. In other words, most of these studies in the New England Journal of Medicine have 200, 300 patients. This has a lot of patients that are completely matched. So if it didn't stand up, it would certainly show up there. But in answer to the question, there is a crossover in anti-platelet activity against blood clots and vice versa.
Okay, great. So I think what Todd, if you're good with this, we have a ton of questions, Sam, and we'd kind of like to do a random question to Dr. Berkman, if you could answer some of these. Todd, I'm going to jump in first, and then we'll just go back and forth. So I thought this was a really interesting question from somebody. They wanted to know why doctors don't test patients before surgery for factor V Leiden or other genetic mutations. This person ended up having orthopedic surgery and then got a blood clot afterwards. When they did do the test, they found out they had factor V Leiden. Why don't they test beforehand?
First of all, 95% of people with a factor V Leiden mutation will never, ever get a blood clot, okay? The reason it's such a prominent factor is its prevalence. 7% of the Caucasian population in this country has factor V Leiden, and that's why it shows up so much. But the fact is that the overwhelming majority of people that have this will never, ever get a blood clot. And you wouldn't treat somebody, I think if they've never had a blood clot, that's a more important factor than whether they got V Leiden, because most V Leidens are not thrombogenic. So if the person tells you they've had a blood clot, don't you think I should get a factor V Leiden mutation? The answer to me is no, because I'm going to treat you as though you had a factor V Leiden mutation, because if you've had a blood clot, whatever you've got is thrombogenic. Whereas by testing a factor V Leiden, I don't have any idea whether that mutation is thrombogenic or not. 19 out of 20 times it won't be.
Really interesting. I didn't realize that the percentage was so high. That's pretty incredible. Okay.
Yeah, and going back to, so I lived the first 48 years of my life as homozygous factor V Leiden.
Homozygous.
And never had problem, and I had had surgeries before. Then I had a severe bloodletting accident where I almost bled to death. As a matter of fact, I had to put a tourniquet on my own leg to save my own life. That seemed to, we were talking about how once you've had a blood clot, you seem to be, seems to trigger future blood clots if you're not careful. That seemed to flip a switch for me. After that first blood clot, then it was just like my blood wanted to clot like a marble in a straw. It was just over and over and over again. Just real quick, can I just go back to compression, because one of the questions that came in, and I just want you to talk about it just one more time. When you mention compression doesn't prevent a blood clot, is that just post-surgery, or is that overall in general?
Well, no one has done a study looking at people who have never had a blood clot wearing compression. I mean, no one's done that study. So you would have to take normal people who have never had a blood clot and put compression stockings on one of them and no compression stockings on the other one, and compare them for all other, risk factors. And no one's done that study. So I can't answer your question But it's not a part of practice. People don't prophylax people who've not no history of blood clots with those things. Plus, you know, they can people get allergic reactions to them, and if they're on too tight, they can, you know, damage the skin. They can cause an infection. So,
But if they have a pair that fits comfortably and it's fitted properly and it makes them feel better and more confident, they can certainly go ahead and wear compression.
yeah, sure. There's no downside. Although, you know, there's no doubt if it makes the person feel better, more secure, and they got it fitted properly, there's no downside to it. Yes.
Gotcha.
Okay. We have another person who's written in they need spine surgery, which is a little bit different than obviously orthopedic surgery. Can you comment on spine surgery? They also were hospitalized for a PE a year ago, 71-year-old female. She wants to know what the risks are associated with spine surgery. She's a previous PE person. Can you opine on that?
Yeah, well, first of all, she's going to obviously need anticoagulation. Now, usually with spine surgery, they start off with mechanical prophylaxis because if you bleed into your spine, you can get paralyzed. So they generally do not start off on day one with a anticoagulants. It's usually day 3 or something like that. But they use mechanical prophylaxis. I'm talking about intermittent pneumatic compression, not head hose or anything like that, the thing you plug into the wall. But she's going to need, yeah, in other words, it's going to depend on how long she's going to be immobilized afterwards. In other words, when it comes to spine surgery, it's individualized, basically. And it's got to do with, because you're not cutting as big an area as you are in a hip, you know, where you're really, you know, manipulating that hip, cutting a wider area. The spine's very compact. So the point is the immobilization afterwards. In other words, she's going to need prophylactic. Is she still on anticoagulants full dose now, or is she no longer on anticoagulants? That's the first question I'd ask about her.
Okay.
But I mean, let's take both. If she's no longer on anticoagulants, but she has a history of a pulmonary embolism, like say a provoked pulmonary embolism, she's going to need post-op anticoagulation as soon as the surgeon says it's safe, and use mechanical prophylaxis in the meantime, and until she is well mobilized. And then what you want to do, once she's well mobilized, I think I would get a duplex scan of her legs to just make sure she doesn't have a asymptomatic clot that she's developed. And getting a D-dimer, I don't think is going to be helpful because if she's been immobilized, it's going to be abnormal. In other words, most hospital patients have an abnormal D-dimer. The test is valuable in outpatients predicting, but not so much inpatients. So with this patient, what I do is if she's she's no longer in anticoagulation, as soon as the surgeon tells me I can start, I would put her on a prophylactic dose. If she's in the hospital or in the rehab, I would give her either low molecular heparin or DOAC. And until she's up and around really well with 70–80% of her baseline, I would keep her on it.
Okay, great. Todd?
Let's see. Let me ask you about, we get a lot of questions about this in the group. After the surgery, to relieve pain, to relieve swelling, just to feel better, what about hopping in a hot tub? What about massages? Are they recommended? If they're not recommended, why? Why are they dangerous? Why shouldn't they be used? Can you give us any opinions on those?
Yeah, well, the hot tub's fine, just as long as you don't fall and hurt yourself. You know, if a person has had hip or knee surgery or spine surgery, their balance may not be all right. So you want to make sure they can get into that tub okay and get out of that tub so they don't fall and hit their head, particularly if they're on anticoagulation. But the tub itself will not hurt them.
Now, what if they have an actual blood clot? What if they have a DVT and it's an active DVT that has not absorbed? Can
Well,
they still get into a hot tub?
Yeah, you know, as far as what heat would do to it, I'm not sure what the data is on that. I don't think it's been looked at. I'd be more concerned about traumatizing themselves, getting in and out of the tub. A massage I would stay away from. If you've
What
got
about
a,
the powerful jets that are in a hot tub that act as a massager?
that's interesting. That's an intro. I've never been asked that question
Mhm.
before. They're not in every hot tub. They're in some of
No.
them. But yeah,
Oh,
that's,
yeah, right. You can activate them, or you can turn them on or turn them off.
I wouldn't add any variables. You know what I mean? I wouldn't add any variables to this
Mhm.
thing. Now, could that do it? I don't know, but I wouldn't add the variable.
Right.
And that same thing applies to massage too. I wouldn't add the variable. If you've got a acute clot, I would not add that. Maybe it'd be okay, but I wouldn't add it in.
Yeah. Talk to your doctor.
Yeah, everybody's unique. Speak to your clinician. Interesting question. Prevention strategies for blood clots, DVT, post-orthopedic knee procedures, X the anticoagulant. So I'm assuming that would be hydration, mobility, etc. In terms of prevention strategies.
Exactly. Yeah. Early mobilization is really important. Really important. That may be the most important thing to get them up and around because it gets that soleal pump working, and that's really important. That's why people should walk the aisles on airplanes, even though you won't find any airline that tells you to do that.
Mhm. Well, if you stay hydrated, you're going to have to go to the bathroom. You're going to have to get up anyway, right?
Yeah.
Question from somebody who borderlines on being obese. They're having knee surgery. And is that a risk factor in addition to surgery itself?
Yes, yes, obesity is a risk factor, but it's been shown that that doesn't mean you need to raise the dose of the anticoagulant prophylaxis for obese patients, either if they in any prophylactic fashion. So in other words, they basically made some recommendations in 2016, the International Society of Thrombosis and Hemostasis, that people with a BMI over 40 or a weight of over 120 kilos, they should either have their factor 10A levels monitored with DOACs, or they should have levels, or they should get higher doses. That's no longer felt to be the case. You can get a normal dose of DOACs in obese patients, whether at treatment or with prophylaxis. So yes, it is an increased risk, but it doesn't involve changing the dose of the prophylactic anticoagulant.
Okay, great. Hey, Todd, do you mind if I jump in with another question here? Because I see it in the chat.
Yep.
So I think this is really interesting. I have factor 2 prothrombin gene mutation and have a complex tear in left knee and loss of cartilage, and left knee has already had 2 scopes. Do you think it is possible to replace Neom on Xarelto 20 milligrams?
Yes, of course it's possible to replace the D. She's got a prothrombin 2021A mutation. So I'd like to know how she knows she has that. Did she have a blood clot in the past? Is that how it got diagnosed? Or does she have a relative and she got checked because she has a relative? Um, either way, I think she can have it. Since she's getting Xarelto 20, then obviously she's had a blood clot. In other words, they wouldn't give her 20 of Xarelto just because she's got the prothrombin mutation. So she's had a blood clot. And like we said in the pause trial, she's going to need to stop it 2 days before. So if her surgery's on a Thursday, she's got to stop it on last dose is Monday. And then they're probably going to restart her a day or two later, but depending upon, like with Todd, how many previous clots she's had or her circumstances. But yes, she can do the surgery. And basically, the way it's handled is just like I outlined on that slide through the pause trial. Stop 2 days before because it's high risk surgery, as we showed, that orthopedic surgery involving hip and knee replacement is high risk surgery. So instead of 1 day holding it, it's 2 days holding it. And then you come back a day or two later and then make arrangements for any special circumstances for the patient.
Okay, great. All right, so we have a few minutes left. We still have a lot of questions. So Todd, I'm going to punt it back to you. and then we'll take a few more, and then we'll wrap things up here with Sam.
Yeah, I'm gonna hit you with two quick ones. Okay. We talked a little bit earlier before we went live about how I was approved for Aleve, for pain medication for my chronic pain. I've been doing that for 10 years. My orthopedic surgeon, trauma surgeon, and the hematologist both approved me. And for moderated use, it's okay. So one of the questions that's come in is what pain medication can be taken with Xarelto? Is the NSAID use, is that just, that depends on the patient? What's your opinion on that?
So NSAIDs do increase the risk of bleeding in conjunction with Xarelto. There's one study done by Bruce Davidson, I believe it showed double the risk of bleeding. So it's really a risk-benefit assessment. In other words, how well is this drug working on relieving your pain? If you're getting a major benefit out of it, and you tend to be someone who really tends to clot, then you're probably more at risk for clotting than you are for bleeding. In that case, I would agree with your doctors, and I would say if it's really helping you, go ahead and using it. If you had shown a predisposition to bleed, I would be much less enthusiastic about doing that. But if you've got 6 clots, no bleeds, and you're benefiting from the drug, then I would explain to you statistically the increased risk that was possible. But I wouldn't stop you from that. I would prescribe it also.
Risk versus benefit. Okay, and the last thing, real quick, because I've been on Xarelto for 12 years. You're with Janssen. The importance of
I speak for them. I'm not with them.
You speak for them. Okay.
So by the way,
so if you're familiar with Xarelto and the dosing, it's important that just tell me this: is it important that it be taken with food? Because sometimes people are told to eat with it for proper absorption. Sometimes they're not told anything. Is there a best practice for taking Xarelto at milligrams of 15 and 20?
Yeah. So with Xarelto, and unlike the other anticoagulants, the other DOACs, is absorbed 100% in the stomach. Okay. So with the 10 milligram or the 2.5 milligram, there's not that much medicine that it can get absorbed in the stomach without food. But with the 15 and the 20, there's so much medicine in there that you need to keep it in the stomach a little longer so it can get absorbed completely. Otherwise, you only get 66% absorption. So basically, what you're supposed to do with the 15 or the 20 milligrams of Xarelto is you take it toward the end of the largest meal of the day. And basically, that's how you take it. And I've found when I've seen people who get clots on Xarelto, 3 reasons. One is that they didn't take it properly. 2 is non-compliance. And 3 is if they were taking a drug that was a inducer of CYP3A4 or P-glycoprotein, like the anti-seizure medications like Dilantin, Tegretol, Primidone. Those are the reasons why people I've found who get clots on Xarelto get them. So I think that
that's kind of what I've been saying. So it's nice to hear you back that up, because it seemed logical to me. My hematologist said those exact 3 same things. So the non-compliance to me is a big thing, because you get a lot of people that are like, well, I missed my doses here and there. I don't think it's a big deal. And I'm like, it is a big deal.
Well, it is a big deal, and it's more of a problem with BID drugs than once-a-day drugs, but it is a big problem.
Thanks, Sam.
I just want to circle back to the pain medication. So, because we don't want people to think that everybody can be on an NSAID if they've got pain. This is really, it does increase the risk of possible bleeding. You need to have that conversation directly with your clinician. Everybody's different, everybody's unique, and it does raise the potential for more bleeding. So please just make sure you discuss that with your doctor. 2 more questions. Am I right in assuming that after knee hip surgery for those first 3 months or longer, I should not take any plane trips or long car rides?
Great question. Great question. Well, unfortunately, not everyone has that choice. Some people really have to go. So I've been in that circumstance where I tell people, if you don't have to add variables, it's kind of like the massage, don't add variables. But some people have to do this. Some people have like a death in the family, they have something, they just have to go. So I try to tell them to postpone trips like that, but if they can't, I'm gonna keep them on a prophylactic anticoagulation. Well, I mean, if they've had a clot, they're on anticoagulation, so they're protected. I think that it's unlikely they're going to get a clot. The risk is very low, and I think that air travel does increase it a little. But don't forget the risk of a clot from air travel over 4 hours is 1 in 4,161. So it's not a high risk factor. It's a moderate risk factor. It's a low grade risk factor. So I think as long as the person's on full dose anticoagulation, and the trip is not elective, I think you can send them without worrying too much.
Okay, great. This is actually not an orthopedic surgery question, but I think it's a really interesting question. And I love that we're doing this bing bong bing with you. This is just great. I'm 3 weeks out from abdominal surgery. I'm still in the danger zone. Or am I still in the danger zone? Still at risk for reclotting. The hospital gave me Lovenox injections while in the hospital for 45 days after surgery, but did not send me home with blood thinners. Important to note, I had COVID-provoked bilateral PEs in March of 2022 and have not been on blood thinners since August of 2023.
Okay, so this is post-hospital discharge prophylaxis in somebody who, did you say they had surgery or they were just in the hospital for
3
medical?
weeks out from abdominal surgery.
Mhm. Yeah, I can see why she's concerned about that. I think that patient, I'd like to know how ambulatory she is. I'd like to know how well she's getting around. I think we might want to consider scanning her or just to see, but I think that I would go a little longer on her. Basically, with medical patients, we kind of have a way of going about this. There's like for the Magellan trial or the Mariner trial, it's people with congestive heart failure who are in the hospital for congestive heart failure, COPD, a stroke, sepsis. Those patients who do not have high risk for bleeding, aren't on dual antiplatelet therapy, we give them 35 days of post-hospitalization rivaroxaban. These are medical patients, not surgical patients. Most post-hospital discharge DVT is medical, not surgical. Interestingly, and somewhat counterintuitively.
Yeah.
That's so. But this woman who's had surgery, she's had a couple of PEs. The thing is, someone who's had a PE, if they're going to recur, they tend to recur with a PE. Whereas someone with a DVT tends to recur with a DVT. And a PE, each one has a 10% mortality. So I think if there's any question, I'd go a little longer on her, and I might get a duplex scan of her legs to see that there's no clots after 35 days. And then I might stop her.
Okay. And we've gone over the hour, so we want to be mindful of your time, Sam, knowing that probably still have patients to see on the West Coast because it's only 5 o'clock there. This was incredible and so interesting. We would love to have you back so we can do this again. This rapid fire questioning was absolutely fantastic. I do want to mention to everybody that NBCA has a toolkit for people who are contemplating orthopedic, particularly knee and hip surgery. That's available probably in our chat and also on our website. So please download that so you all have access to it. It's a great resource. And Todd, would you like to have the final words?
Well, I just want to say we've had people pop in late and they're wondering, they're upset because they missed it, but we will have this recording in our PEP Talk library like we do for all of our episodes. Great education in all those PEP Talks, and so once we get this edited down and all polished up, we're going to get that live, and it'll be on the NBCA site, and also we'll talk about it in the group and make sure everybody knows.
Yeah, and I just want to say, I mean, we live this every single day at NBCA, but Sam, we personally learned so much from you tonight. It was amazing.
Yeah, absolutely.
Thank you.
Thanks so much, Sam.
So thank you.
It was a pleasure and an honor to be asked. You got 32 real experts on your board, and the fact that you chose me is a real compliment. So thank you.
Thank you.
Thank you very much.
Okay.
Happy New Year, everybody.
Bye-bye.
Bye-bye.